laboring process and ultimately deliver this right. So mom will come in and they'll place mom and the baby on some sort of external monitoring, typically because oftentimes they don't have rupture of their membranes. We're looking for contractions for mom. Remember, for contractions, we want greater than 200 Montevideo units, and over a 10-minute period. And that's enough contraction strength to bring about the changes that we need in the cervix to allow the door to open. We think of the cervix as a door, and then allow labor to progress. And then you want to remember, as you're studying, to look over the things that we're looking for baby. Accelerations, fetal heart rate. We're looking for those decelerations, and remember the difference between early deceleration, variable, and late deceleration. Make sure you understand what each of those mean when you see them. And then what do you do about the non-reassuring patterns? What are your interventions? You guys can use the Veal Top Mind mnemonic if you want, or however you want to remember those things. But sometimes labor and delivery doesn't go as planned. So we're going to talk about what happens when it doesn't go as planned. So about 3 to 4% of pregnancies can have a breech presentation. Breech means buttocks down. And this, unfortunately, especially if mom is trying to deliver the breech baby, increases perinatal mortality. So mom and fetal baby mortality. So the recommendation, if this is identified earlier on, is the baby cannot be moved from that position, really is to do a C-section delivery for these babies. And sometimes the presenting part will be the buttock specifically, sometimes there'll be a leg out, sometimes there's 2 legs out. So you'll go in there to do the cervical check and you'll feel a foot, or you'll feel a hand, or you'll feel 2 feet. And that's an indication that most likely this is not going to do well for the vaginal delivery. And then they can make the decision at that time if they want to do C-section, or they can schedule a C-section prior to when if they're not able to do it. But what they'll try to do is about 36 to 37 weeks, if they identify that this baby is breech, they're going to try to move the baby with their hands. They will physically try to move the baby. And guess what? This is painful for mom. This is very uncomfortable for mom. It causes some agitation in baby as well, but they feel like if they're able to move the baby, the benefit outweighs the risk of moving the baby. Right? So if we can get baby head down, we can do a vaginal delivery as opposed to having to do C-section delivery. Again, because they're physically trying to move baby, there is an increased risk of placental rupture. There is an increased risk of rupturing the amniotic sac, increased risk of pushing mom into labor as well. And that's one of the reasons why they don't try it earlier than 36 weeks. The other reason why they don't try it earlier than 36 weeks is because there's still room for baby to move. So at 36 to 37 weeks, there's not a lot of room left in there for baby to move. And again, because it's a fairly aggressive movement pressure, there is a potential for blood mixing. So any time this is performed, if mom has an RH negative, they will give RhoGAM. Oftentimes around that 36 to 37 weeks when this is initially done, it's done without anesthesia. So again, mom will definitely feel it, and she'll just complain of a lot of pulling and a lot of pressure and feeling uncomfortable. If they are successful in being able to turn baby vertex down, which is head down, there is still about 10% that baby's not going to pay attention, baby's going to flip back around some way. And so again, they're going to continue to monitor and see if they can try this maneuver once again. So external cephalic version is what it's called. So try at 36 weeks and do it again at 37 weeks if they need to, again at 30, and then again at 39 weeks will be the latest that they're going to do it. And usually at 39 weeks, they'll actually, with associated with some sort of anesthesia. They may have scheduled a C-section delivery, but they're going to try to do it one more time. They'll do an epidural, and they'll try to move baby back into vertex position with the plan to do a C-section if needed. But if they're able to get baby vertex down, then they can induce labor if the absolute contraindications for external cephalic version is anything that would preclude vaginal delivery. There's no reason to turn baby if we're not going to have a vaginal delivery anyway, right? So if we have a placenta previa, if there is the cord is the vasa previa cord is in front of the head, if this is a multi-fetal pregnancy, then we also don't want to do it. So anything that precludes vaginal delivery will preclude external cephalic version. There's no reason to contraindicate it. There's no reason to do it because we're not going to deliver vaginally anyway. So sometimes labor goes really, really quick. And for those that have been in labor, it sounds like a great idea, right? We call it precipitous labor. So pretty much mom comes in and within 3 hours, she has delivered the baby. Right? So again, sounds great, but we're talking about really quick cervical change. We're talking about, we're asking the body to respond and get ready for this baby in a very short time. You're asking mom this entire time has been prepared for the latent stage of labor. We're going to the active, so latent might be 11 or 12 hours. We're going to the active, you've got 4 to 6 hours. In their mind, they're prepared for this, right? So now you're saying, oh, no, you're going to deliver this baby within like 2 to 3 hours. That's a lot of stress for mom. That's a lot of stress for baby as well. So again, instead of a normal 2 centimeters per hour of dilation of that cervix, now we're talking about 5 centimeters now. Within 2 hours, that cervix is completely dilated. There's a lot of complications associated with it because the body's not ready for it. Increased chance of uterine rupture, increased chance of significant lacerations in the perineal area because the baby's coming out so quickly. It's almost have no time to be able to kind of slowly bring the baby out. Increased risk of uterine atony, which means the uterus doesn't tighten up the muscle tone, which then ultimately leads to a higher chance of postpartum hemorrhage as well. And then placental abruption, we just pull that placenta right away from the lining of the uterus. Again, because this is very stressful for baby as well, we can have meconium. Meconium is that first baby poop. And if baby poops in utero, as soon as baby feel kind of exits the maternal pelvis, all the bubble, they'll take a big deep breath and then they'll breathe in that meconium, that's meconium aspiration. That causes a lot of problems with lungs. We can have brachial plexus injuries associated with this as well. And we don't really know exactly why some women will go into precipitous labor, have precipitous labor, but cocaine, once again, rears its head as one of the more common causes of precipitous labor. We like cocaine, so we talk about cocaine all the time, but not in the military, outside of it. On the other side of that is labor dystocia. Okay? Labor dystocia is where it's called dysfunctional labor, and here things are slowing down. They're not going as planned, they're going too slow. So instead of having that 2 centimeters an hour, we're maybe like a half a centimeter an hour, or even less than that. So really, we're not getting the dilation of the cervix that we want. The labor process, is going too slow. Oftentimes, this is due to 4 different things. We think about power, meaning really contractions. So mom's contractions aren't strong enough to bring about that cervical change. Right? It could be because mom has had some medication to help with the labor pain. It could be because mom has an epidural and so she doesn't feel that need to push. And that's oftentimes why they'll wait a little while to do the epidurals until they're at least 5 or 6 centimeters, 6 or 7 centimeters dilated, so they have some of that pushing already on board. Okay. It could be related to psych, so we got the 4 P's. Psych meaning, again, stress or anxiety with mom, maybe sedation from medication mom's had. It could be related to the baby itself, the passenger. If there's any fetal abnormalities, maybe the fetal lie, maybe the baby is not vertical. Maybe you're transverse. Maybe it's the fetal head malposition. Maybe baby is up instead of occiput down, or occiput up instead of occiput down. And maybe it's macrosomia. So maybe the baby is diabetic and the baby is large, and so the baby is not descending down into the birth canal. And then passage. Passage is the maternal bony pelvis. Especially if mom has some sort of injury to her pelvis, maybe the pelvis is contracted, and so they don't have the inlet for the baby to come through, it's not as large, and so that could be a cause of this as well. And essentially, baby is not descending down, or if the baby did descend down, the laboring process is not continuing like we should at 2 centimeters or more. So, well, as long as there's no evidence of maternal or fetal issues, then we could actually let this ride. We could just see how well the body takes care of this. We call it, art of medicine, right? So again, we allow the body to do a natural process. And the natural process, they know, is to continue on with this labor and delivery. So we can allow that, as long as the monitors are reassuring. If the monitors become less reassuring or mom is still not progressing, then we can do things like induction or augmentation. Okay? If that does not work, then they may plan for an operative delivery. So it could be a C-section delivery. They might use something like vacuum-assisted delivery as well. But usually, if they can't get mom to labor appropriately, then they'll schedule for a C-section. They turn it from a vaginal and then move it over to a C-section delivery. Sometimes this labor dystocia occurs from the very beginning, from that latent phase. So instead of that, 11 to 12 hours, now we're talking 12 to 24 hours. And sometimes it only occurs in the active phase. So active phase, we think about the cervix is already dilated, at least 3 centimeters, but here we're thinking about 6 centimeters dilated for the management of this prolonged active phase of labor. As long as the cervix is dilated at least 6 centimeters, sometimes what they can do, they can go in there and break the amniotic sac. By releasing that fluid, that allows the baby to descend further down into the maternal pelvis. Okay? Because that fluid is kind of acting like a cushion. And because it's acting like that cushion where there's a cushion underneath the baby's head, the baby is not able to descend down to the pelvis. It also allows for internal placement for internal monitoring, so they can monitor the baby a lot closer as they're going through this labor and delivery process. Because we are rupturing the amniotic sac, there is an increased risk for infection, so they're going to monitor mom for increased risk of infection as well. If mom is not contracting well, again, we're still 6 centimeters dilated, but mom is not contracting well, less than 200 monovideo units, or at 10-minute period, we can augment the labor. We can give mom medication to augment her contractions. Let's make those contractions stronger, right? We're going to continue to monitor mom and baby for at least 2 and upwards of 4 hours, sometimes even up to 6 hours as if this is a singleton pregnancy, and this is the first pregnancy. As long as contractions are adequate, the fetal and maternal monitoring is reassuring, then they're going to continue to monitor these patients and try to, again, push them through to ultimately deliver vaginally. If the 6 hours has gone by, mom's labor is still not progressing, then ultimately, or if there's any evidence on the monitors of non-reassuring patterns, then they're going to schedule mom for the C-section. So when I say schedule, mom is already in labor. Mom's in labor and delivery unit. They're going to move her from there over to the operative unit for C-section. I'm not going to send her home and bring her back. We're just moving from one area to another and go directly to a C-section. Okay, so induction and augmentation. We've used those words multiple times since we started talking about labor and delivery. We think about induction, we're trying to induce labor, we're trying to start labor. So these are women that are not laboring, okay, or not laboring appropriately. They're not even having contractions, they're not having cervical dilation. And so what we want to do with these patients is we want to help them start the laboring process. Sometimes that includes dilating the cervix. If the cervix is not dilating appropriately, again, that's our closed door. So they'll dilate the cervix, and oftentimes if you can just dilate that cervix manually, and that will stimulate the contractions and stimulate that labor process. And then augmentation. Mom is having some contractions, having some laboring, but not enough to bring about those cervical changes. So we're going to augment what is going on. We think about induction. Induction usually occurs at about 39 weeks. Now we know that there are certain reasons that they're going to induce earlier. Think about preeclampsia as one of the things we talked about. So if mom is preeclamptic, that is not a reason for C-section delivery, but they can induce mom earlier, and ultimately mom should still be able to have a vaginal delivery. But they're not going to typically let her wait until at 39 or 40 weeks to have the baby. They're usually going to induce at around 37 weeks. Okay, so some kind of medical reason we can induce earlier than 39. But if mom is otherwise healthy, baby's otherwise healthy, and not started having contractions or labor process, then induction can be started around 39 weeks. And the things that we have to think about before they induce, we got to verify that mom is in fact 39 weeks. So they're going to go back and look at that first trimester ultrasound. They're going to make sure that the fundal height measurements are going along with the ultrasound. And they're going to ask mom, when did you first start feeling this feeling? And quickening is kind of a, because it can occur from, anywhere from 16 to 22 weeks. It's still one of those things that they want to ask. And then they also want to figure out, are we having any cervical changes at all? There's no reason to give mom medication to increase contractions or start contractions if the cervix isn't ready. Okay? So we're going to have to give medications for the cervix first, and then ultimately give medications to start the labor and delivery process. So we use this thing called the Bishop scoring. The Bishop scoring says, how ready is the cervix? Is the cervix dilating appropriately or not? Okay? So that Bishop scoring is going to help us decide if we start medication for induction, is it going to be successful? If we have a Bishop score of less than 4, equal to less than 4, that means the cervix is not ready. We need to make the cervix ready. Okay, if we have a Bishop score greater than 9, that means we don't need to do anything with the cervix. The cervix is dilating appropriately or is dilated appropriately. Now we need to induce labor. We need to have mom start contractions or augment those contractions. So this is our score, our table for Bishop score. I wouldn't memorize that, but I would know if it's less than 4, it's not favorable. If it's greater than 9, it's favorable. So if we have a low Bishop score, we've got to focus, excuse me, initially on cervical ripening. Okay? Cervical ripening, they were trying to thin and dilate that cervix in preparation for labor and then ultimately deliver. And the first thing they can do is they can do something called membrane stripping. This is not rupturing the amniotic sac. This is purely stripping the amniotic sac away from the endometrium, away from the lining of the uterus. And oftentimes, just by doing that, that will cause dilation or ripening of the cervix. We can do mechanical dilation. So mechanical dilation, they'll take something like a Foley or a luminaria, some sort of balloon, and they'll put it into the cervix, and they'll start kind of pushing air into that balloon, and they'll manually dilate the cervix, forcing that cervix to be open. Okay? Or we can use something like prostaglandins, like misoprostol or Cervidil. Misoprostol is a pill, and that pill goes up by the cervix and starts to thin and dilate the cervix. And then Cervidil is it's a string that has medication. And again, that goes up in front of the cervix, and it releases prostaglandins and ultimately will thin and dilate that cervix. Okay? Now, if mom is already in active labor, okay, she's already in active labor, we don't need to use these ripening agents. Okay? She's going to have cervical changes. Okay? This is mom is not laboring, we don't have any cervical changes. So you see cervical changes, there's no reason to dilate the cervix, it's already happening. This is membrane stripping. Again, they're not rupturing the amniotic sac. All they're doing is stripping the membrane away from the endometrial lining, as you can see that. And that's usually done with just a finger. They'll go in there and they'll feel, and that's also uncomfortable for mom, but again, fairly well tolerated. Not as uncomfortable as delivering the baby. So once that cervix is ripened, we gotta ripen the cervix first. Once the cervix is ripened, oftentimes that will stimulate labor, meaning it will stimulate contractions for mom. And then the cervix will continue to thin and continue to ripen. Okay? If that does not happen, okay, then we're going to give oxytocin. And when we think about active management of labor, which we talked about in our last class, the thought is that we really should do oxytocin on everybody, no matter what. Certainly, if they're not laboring, oxytocin is going to be started for the induction. We want to start that laboring process. It causes contractions, but it does not help with ripening of the cervix. That's why we have to ripen the cervix first, or make sure the cervix is dilated, because it's not going to. If you're giving mom contractions and the cervix is closed, all she's doing is having contractions against a closed door. Very, very painful, but it's not going to change the cervix. And so what this does is it's released, we have like a natural form of oxytocin, and it causes distension of the birth canal. It can also cause mammillary stimulation, or if we do mammillary stimulation, you can have release of oxytocin, but the problem is it's not going to be enough, okay? So we don't just do stimulation of the nipples during delivery to try to get enough oxytocin for them to start having contractions. It's typically going to be an irregular amount, not going to be enough. So IV oxytocin is what is recommended for induction, and we can control the amount of oxytocin that we're giving these patients, because sometimes we have to increase it, sometimes we have to decrease it. Okay. Again, augmentation, so mom, cervix is right. Okay? And she's having some contractions, but the contractions aren't enough. Okay? The contractions aren't strong enough to bring about continued changes in the cervix and to help the fetus descend down into the birth canal. We're going to augment those. And we want greater than 200 Montevideo units. So one of the ways they can do this, they can do that amniotic rupture, rupture of the amniotic sac. Okay? If they do that, mom is essentially going to be in bed for at least 30 minutes, because they want time for the baby to descend down in the birth canal. So if we rupture that amniotic sac and allow mom to get up and walk around, okay, there is a likelihood that that umbilical cord will slide down in front of the baby's head, and now we'll have a vasoplegia. So once they do an amniotic sac rupture, mom is in bed for at least 30 minutes, allows the contractions to start taking hold as well, and push baby down and keep that cord up above baby's head. If we do identify that there's a cord prolapse, then that is an indication for a stat C-section, so emergency C-section immediately. How do we augment? We augment with the same medication we induce with oxytocin. Okay? Again, we don't typically do immunostimulation because we can't control the level. So oxytocin is used for both induction and those contraction augmenting those contractions. Here are some specific indications for induction augmentation, and I would definitely review these, okay? So preeclampsia, diabetes, and not diabetes by itself, but why would diabetes be a reason for induction? Macrosomia, big babies, okay, big babies. We got to get that baby out somehow. And if at 37 weeks, baby's already 10 pounds, well, it's going to be hard to get that baby out at 40 weeks, so they're going to induce earlier. If mom has some heart disease, then they may talk about inducing a little bit later. We've got placental reasons as well. So a couple of things that we talked about. So intrauterine growth restriction. If baby's not growing inside, we're going to have mom deliver baby early, and and then they'll feed baby once we get it out. And that's usually monitored. They're gonna monitor mom over a few weeks and allow baby the chance to increase weight. If that doesn't happen, they'll induce failure. If we have premature rupture of membranes, okay, oftentimes premature rupture of membranes, we're going to have to induce these patients usually within 24 hours. If there's an ascending infection like chorioamnionitis, that is an infection of the chorion, which is essentially the fetal part of the placenta that can get infected, usually sometimes from bacterial vaginal infection like gonorrhea, chlamydia, bacterial vaginosis, or if mom had premature rupture of membranes. And then other things, if this is a prolonged pregnancy, meaning what? After how many weeks? 42 weeks. So for over 42 weeks, we got to get this baby out. Right? So they're going to induce mom. Other reasons for augmentation, mainly if they have a prolonged latent phase, so mom is now 12 to 14 hours into this latent phase, and we're not really seeing much change, they're going to start augmenting. They're having some contractions, they're going to augment those contractions, or even that prolonged active phase as well. Specific contraindications, which I would also be familiar with, okay? Anything that would preclude vaginal delivery, placenta previa, vas or previa. If mom has, a pelvic anatomy is not going to allow for vaginal delivery, then you can't, there's no reason for induction augmentation, right? It doesn't make any sense. We don't need to induce, we're going to do a C-section delivery on those patients. If mom is having a genital herpes outbreak or a prodrome, okay, meaning I'm having a burning sensation. I don't have any lesions, but I'm having burning. I feel like it's going to, they're never going to do a C-section delivery. I'm not going to deliver through that because even without lesions, if we still have a vertical transmission of the baby. Okay. Relative contraindications, you don't really need to be familiar with those, but to think about if mom has had some sort of like a prior C-section or prior uterine surgery, the myometrium just isn't going to be as strong as it once was. And so the thought is if they're not laboring appropriately, maybe we should just do another C-section, because by increasing their contractions, there's an increased risk for abruption of the uterus. Okay? But again, that's a relative. And then for the baby, if there's any evidence of fetal distress, they're not going to induce, they're going to do a C-section delivery, right? So if there's evidence of fetal distress, we're not going to induce mom, we're not going to allow baby to stay in there, we're going to do an emergent C-section for that. All right. There is something called tachysystole. Tachysystole. Contractions are too much. We don't need augmentation. We need to actually take, if we're giving Pitocin, we got to take some of that away. We are having contractions too often, okay, they're lasting too long, and they're having too many of them. So normally we think about contractions initially, when we go into that latent phase, by every 10 minutes, and then they're going to be increased from there. These guys are having contractions like every 30 seconds, or they're having 30 seconds, and then they last about 2 minutes. And then they'll have about 30 seconds off, and then they'll have it again lasting for 2 minutes. And usually that's not the case. Usually, by the time they're deep into the laboring process, it's every couple of minutes, but then they have a couple of minutes off. Right? So these guys are having really, really quick contractions, usually more than 5 contractions in just a 10-minute period of time. Okay? And it's often caused by oxytocin. So again, if that's the case, if you have oxytocin, and the majority of times, I would say nowadays, probably at least 98% of the time, they're going to have oxytocin on as part of the active management of labor. So if that's the case, they're going to reduce that oxytocin drip, or even maybe shut that oxytocin drip off. Okay? There's increased risk for not only significant maternal discomfort, but if mom is uncomfortable, baby's going to be uncomfortable as well. So we're going to start to see signs of deceleration, signs of fetal distress by looking at those fetal monitors. And remember, our fetal decelerations that we'll see, variable decelerations. Okay? Maybe we'll see late decelerations as well. Depends. So cord compression or uteroplacental insufficiency. Okay? So again, if we're augmenting, we're going to discontinue that or at least reduce it. Put mom on her left side. And we want to make sure that there's no evidence of core entrapment, so we'll do a manual exam and feel around the baby's neck if they maybe give them oxygen. They may also give terbutaline. Terbutaline is the only FDA-approved medication to put for taxicystole. And essentially, terbutaline just reduces the amount of contractions that they have. So some of these things should look familiar when we talk about deceleration. If we see that in fetal monitoring, we've got that same thing, discontinued augmentation, mother on her side, oxygen, and the same things we talked about for deceleration. Okay, chorioamnionitis, that's an ascending affection that can occur of the membranes and of the amniotic fluid. Typically going to be a polymicrobial infection, and oftentimes occur in patients that have amniotic sac rupture, usually greater than 18 hours. Right? 18 hours is usually what you're looking at. Okay? Other risk factors, if we have multiple digital exams, and guess what we do during pregnancy and during labor and delivery? Multiple digital exams. We got to make sure that these are sterile exams, or we use a sterile glove every single time. Okay, oftentimes, if they have to do a speculum, they'll do a sterile speculum. Most of the time, they don't do speculum exams, it's just digital exams. They're doing everything by feel. Okay, even the placement of an intrauterine pressure catheter. So the amniotic sac has ruptured. Now we're going to put a catheter on baby's head, the fetal scalpel electrode. Placement of that electrode, you can introduce bacteria, and then several hours later, mom's going to start fevering and showing signs of infection. The problem with chorioamnionitis is not only maternal morbidity mortality, you have fetal morbidity mortality increase, and then increased rate for C-section. It's not an indication for C-section, but people women that have chorioamnionitis tend to have increased rates of C-section because of the infection and because of the labor dystocia that's often associated with the infection. So how do we diagnose this? Fever, and then at least 2 of the following. So tachycardia can be maternal or fetal. Remember, fetal tachycardia greater than 160. Abdominal tenderness, okay, leukocytosis on labs, or of course foul culture positive amniotic fluid. Usually not going to have amniotic fluid culture at the time. And so you got to go with mom starts fevering or starts becoming tachycardic, or fetus starts becoming tachycardic. A lot of times we'll identify it in the baby first, and that's an indication that something's going on with mom. Then that is very concerning, especially if this occurred during the laboring process. Okay, so the treatment is delivery. You want to deliver, usually you have to induce because a lot of times this leads to labor dystocia, and then antibiotics. Right? So these patients need broad spectrum antibiotics. You don't need to know the antibiotics, but you put on antibiotics. They'll be continued for at least a day and oftentimes 2 days after delivery. Again, not an indication for a C-section. Baby can still deliver vaginally, but oftentimes will have to be induced because this can cause labor dystocia. The other problem with chorioamnionitis is increased risk for postpartum hemorrhage. And so these patients will be monitored very closely for at least 24 to 40 hours postpartum to make sure they have no indication of hemorrhage. Okay. We have shoulder dystocia that can complicate delivery as well. Shoulder dystocia, and really it's usually the anterior shoulder gets stuck up underneath the pubic symphysis. And if someone's had a history of shoulder dystocia, there's certainly an increased risk in subsequent pregnancies as well. What happens with these babies, their head will come out, and you're like, yes, but then their head will go in. And then their head will come out, and then their head will go in. Because the shoulder is stuck. So we're already in the process of delivering the head. The head is out. Okay, it's at the end of the vulva, or out of the vulva a little bit even. Okay, we're like getting ready to section, but then it keeps coming, we can't get that shoulder from underneath the pubic symphysis. Right? So this is, you can imagine, very, very stressful. And so as soon as this happens, people are moving super quickly. I've seen this happen probably a half a dozen times. And then you never, like the nurses, OB nurses are amazing. The midwives are amazing. These guys, as soon as this happens, they've got mom doing all sorts of maneuvers to try to get this baby and stuff. Okay, so if baby is bigger, macroscopic baby, that's increased risk shoulder dystocia. Of course, mom is bigger as well if there's a prior history of shoulder dystocia. Complications, increased risk of postpartum hemorrhage, right? Increased risk of vaginal lacerations, perineal lacerations, because now baby is stuck going in and out, and we're dilating, we're just tearing everything up in the same token. Okay, increased risk of flexopathy. So we talked about that. You guys remember what that's called? Erb's palsy. Erb's palsy. Usually within a year of life, that palsy goes away with a full activation of their shoulder. Clavicle fractures, we talked about that as well, and actually trying to break the bone to pull the shoulders in closer together so they can get the baby out. And then certainly hypoxia, okay, because the baby's head's not fully out, it's halfway in, halfway out. And it's hard to give baby oxygen where they're still in the stuck in the vagina. Okay? And so within 5 minutes, we have a very short time period to get these shoulders unstuck and get the baby out of there. And so the first thing you want to do is, oh my gosh, I need some help in here, right? First thing you want to do, I need some help. And then we can use this helper mnemonic to help us remember the different steps. And here's the thing, this goes in order. This is how they do it. They first call for help, and then they do the next one, and then they do the next one. Okay, so let's go through these. So help, I need some help in here, right? The next thing they're going to do is an episiotomy. So remember, episiotomy is a surgical cut. Okay, we're trying to open up the area for the baby to come out so we can have a larger area, so we can try to push those shoulders together and get baby out from underneath that pubic symphysis. And most of the time, they're going to go midline, so there's a fibrous area between the vagina and the rectum. They're going to cut that fibrous area, using midline, then over to the side as well. Okay? They don't want to remember, baby's head is right there. So they'll use something like a Metzenbaum scissors, but then they'll put their hand on the other side, but they don't slice open baby's head, because then if they do that, the head is very, very vascular. There are other complications associated with that. So that's the first thing that they're going to do. If they don't do an episiotomy, we have the risk for these tears. Okay, so we want a surgical cut, more controlled cut. If you don't do that, we have increased risk for these lacerations. Okay? Vaginal lacerations, they will range from the 1st degree all the way to a 4th degree. And you see this box, know those stuff, and know if it's 1st degree, 2nd degree, know what it entails. You will be asked a question on that. Okay, and of course, it doesn't only complicate, pregnancy now. We've got to, after the delivery, they've got to go in and sew all that up. This results in long-term issues. Okay? A long-term dyspareunia, a lot of problems with incontinence of bowel and bladder as a person gets older. And typically, again, this is repaired after delivery. It's going to be repaired with vaginal procedure. You know those degrees of vasculature. If they're still not able to get baby out after doing the episiotomy, the next thing we're going to do is a McRoberts maneuver. Okay, McRoberts. That's leg hyperflexion. So that's your L and your helper. And again, this is, before you know it, the nurses, one's on each side of mom, and they got her legs pulled all the way up to her chest. Okay, it does not widen the opening of the vaginal canal, but it changes the angle. We're trying to get that top shoulder unstuck. So it changes the angle, and oftentimes we'll release that shoulder from underneath the pubic symphysis. And this is what that looks like again. Usually both legs are completely up on mom's chest. And this lady here is also pushing suprapubic pressure right here, trying to get that baby's that anterior shoulder unstuck. So that's our next one, is suprapubic pressure, usually in association with that McRoberts maneuver. And all we're trying to do is just push that shoulder down so we can get it from underneath the anterior, the pubic symphysis. If that doesn't work, our E in helper is enter the vagina. So you actually take your hands You'll take baby's head kind of around their neck area, and you're gonna start rotating the baby. Rotate the baby down, okay? And see if we can get that shoulder unstuck by rotating them. If you can't, and that's a ruined maneuver, you can't, you're gonna rotate the baby back all the way around, and that's a wiggle. We're doing a corkscrew maneuver. We're just trying to release his shoulder from underneath that pubic symphysis by moving baby back and forth. Okay, if that doesn't work, we're still gonna be in the vagina, we're gonna actually take that posterior arm, and what happens is you take your hands and you go right down, you can feel the posterior arm, and you come down at the elbow, and then you're gonna take at that elbow, bring it across the abdomen, come all the way up to the hand, and pull the hand out of the vagina, okay? And you're trying to, again, still get those shoulders unstuck. And then the last thing, if that doesn't work, we're rolling on over. Okay? Rolling on over on all fours. It's called the Gaskin maneuver. And what we're trying to do with this one, we're actually trying to get that posterior shoulder to descend further down into the pelvis to allow that anterior shoulder to be released. So those are the mnemonic, and again, those go in order, and I would review that order. Okay, so if you, first thing you say, you know, I call for help, a pediatric done, what would be the next thing that you would do? Okay. All right. There's always a risk for cord prolapse. There's always a risk for cord prolapse. We talked about vasa previa in the past. Vasa previa is where the cord is in front of the cervix and in front of baby's head. So you've got the cervix, you got the cord, and then you have baby's head. But this is the cord is actually outside of the vagina. Okay, it is prolapse outside. And this increases if it's a non-vertex presentation, meaning like more like a breech presentation or a transfer line. If you have fetal malpositioning, you have an increased risk of cord prolapse. If baby is intrauterine growth restricted, there's a lot of movement in that, still a lot of room left in the uterus, so baby can move around, and the cord floats around as well and get down below baby's head, and then come out. If there's too much fluid, or if there's too little fluid, both of those are risk for cord prolapse. And then sometimes we cause the risk, right? We artificially rupture those membranes, right? And that increases. We place that feloscalpal electrode. All of those are maneuvers, kind of pushing the baby around a little bit and allow that cord, or the cord to slip down around baby and then outside. So if we do active rupture membranes, these moms have to lay down flat for at least 30 minutes afterwards to allow that head to engage. And if we have cord prolapse that is identified, okay, the first thing to do is take that presenting part and hold on to it. Okay. Trendelenburg mom, okay, we're going to give tocolytics, and then this is going to be a stat C-section. Cannot deliver baby vaginally through that. So we'll hold on to the presenting part, Trendelenburg, and then we'll immediately prepare mom for a C-section. Okay. We can get something like terbutaline, because we want these contractions to stop. Okay. We don't want mom to keep pushing. Don't push, stop the contractions, and then prepare for C-section. All right, some other indications for C-section, question. Okay. If labor is not progressing, okay, despite induction, despite augmentation, we can't get the cervix to have any changes, and that would be an indication for a C-section. Umbilical cord prolapse, okay, vasa previa as well. Any evidence of fetal distress. How are we going to identify that? By the fetal monitor. Okay, we're going to look at that top strip, and we're going to look for those non-reassuring patterns. Okay, active genital herpes or prodrome, if it's a macrosomic baby, if they can't induce early, then they may schedule for a C-section. If it's a breech presentation, it is recommended. And then something like placenta previa. If mom has any cardiac issues, if it's a multi-pregnancy, so two or more fetuses, then typically we'll schedule for C-section. All right. So last thing we're going to talk about is postpartum hemorrhage, one of the major causes of pregnancy-related mortality. Usually occurs within 24 hours, but actually postpartum hemorrhage can occur even 12 weeks after mom delivers the baby. It is defined as greater than 500 cc's blood loss in vaginal or 1,000 cc's lost in a C-section. The most common issue, the most common causes of postpartum hemorrhage, tone. The uterus is not tightened up. The myometrium is designed to house the baby. It's strong, but it's not tightening up. The muscles are not coming back together. Tissue retained products of conception. Maybe a piece of the placenta is retained in there. Trauma, we have vaginal leverage. Sometimes you can even have cervical lacerations. You've got to go in there and look to make sure the cervix is not lacerated. But vaginal laceration, okay? And then coagulopathy. Mom has some sort of underlying coagulation disorder and continues to bleed because of that. Remember, these are usually otherwise healthy people. And so you're not going to see an immediate change in their blood pressure. You're not going to see immediate change in their heart rate. By the time you see a change in the blood pressure and heart rate, mom has already lost a significant amount of blood. Oftentimes, upwards of half of their blood volume before you'll see much of a change in their vital signs. Lots of things. And you only have to memorize the first column. No, I'm just kidding. You don't have to memorize any of these things. No tone. Okay, no tone is one of the main causes of vaginal bleeding, the primary cause of postpartum hemorrhage. Okay, but the problem is we're not very good at estimating blood loss. Okay, so I don't know if anybody here is operating technician before or surgical tech. You know, if I imagine this, if there's this much blood on a 4x4, then this is how much blood. If there's this much blood on a 2x2, whatever, the blood abdominal pad. But we're just not very good at monitoring. Most of the time, we underestimate blood loss versus overestimate it. Especially with those lacerations, they're going to have like this slow bleeding occur, not this bright red gushing of blood that makes it obvious that they're bleeding. If they're having bleeding inside the uterine cavity, the uterus can hold well over 1,000 mLs. So a good liter of fluid can collect in the uterine cavity and really mom still be fairly stable. Patients that are preeclamptic, they don't need induced. Remember, their blood pressure is high from the start. And so we can't monitor, really rely on their blood pressure because, you know, they may be 120 over 70, you're like, that's perfect. Yeah, but they were just 180 over 110, right? So we can't rely on that. So we're estimating our blood loss. You're looking at an H&H for every 500 mLs of blood loss. We're going to see a 3% drop in our hematocrit. 500 blood loss, 3% drop in hematocrit. I would definitely know because that's important clinically. When you guys are seeing these patients, it's important for you to understand this. All right. Do you want to take a break or do we want to finish these 4 slides? Okay. All right. So again, most risk within that first hour. We think about the first 24 hours is kind of our higher risk. But oftentimes we can see uterine atony or feel uterine atony in that first hour. Once we deliver the placenta, the expectation is that uterus is going to start to tighten up. Okay? You can feel it because you're going to do fundal massage. I can't tell you how many fundal massages I did in phase 2. I was the fundal massage person, right? And so it's really cool because you can just feel it tightening right underneath your hand. Okay? Indications that that's not happening is you're going to, while you're pushing on the uterine fundus, it's just like, I'm doing this, it's not getting any tighter, it's not getting any tighter. And so you'll feel this boggy, soft uterus that's persistent. Usually within a couple of minutes of doing your fundal massage, you can feel that tightening. Again, we want to think about what could cause it. Maybe there's a blood clot, maybe there's receding placenta. If there's a laceration, we should be able to see that. If you don't see anything externally, now it's time to do an internal exam. You've got to look at the vaginal walls. And you've got to look at the cervix and make sure we don't see any lacerations there. If it occurs after the first 24 hours, about 1%, then oftentimes it's more related to some sort of coagulation disorder. Okay? You could still have retained products of conception, so recommendation if they come in to see you a week or 2 later, they're still bleeding, do a transvaginal ultrasound, make sure they don't have any retained thyroid protection. And then we want to, if that's the case, then the treatment would be something like a DNC